Good afternoon, everyone, and welcome to our weekly Multi-Modality Imaging Conference. And this week, I'm very pleased to present a unique set of lectures for this week and next week. We actually have our graduating advanced imaging fellows doing their kind of end of the year graduation presentation on either an interesting case or a topic of interest or some of their research. So we're going to start off first with Dr. Pimprapa Vejpongsa. I hope I got that right. After 2 years, we all refer to her as Prim, which is a much easier way to say it. Prim came to us 2 years ago and has done multimodality imaging, and she's going to leave here with training in cardiac MRI, cardiac CT, as well as nuclear cardiology and echo. And Prim came to us from the University of Texas, and she'll be staying in Houston, joining a private practice setting. So Prim, I'm going to turn it over to you, and you're going to talk to us about the role of CMR in hypertrophic cardiomyopathy.
Thank you so much, Dr. Shah. Thank you, everyone, for joining us today. So today I'm going to present a role of CMR in hypertrophic cardiomyopathy. So we have only 15 minutes, so I'm just going to get started on when should you order CMR. These are the 3 common indications that we see every day in our practice. So first off, an inadequate information from echocardiogram. So it's actually class 1 indication to order CMR in this case. So both European guideline and also ACC AHA guideline agree on this class 1 indication. So why CMR? So CMR actually has high spatial resolution with sharp contrast between blood and myocardium, so we can actually accurately measure the LV thickness. And CMR also has complete tomographic image of the entire LV, so we can actually see the focal hypertrophy, LV apical hypertrophy, and LV apical aneurysm, which can be difficult sometimes with echocardiogram. So there's actually a study comparing the LV measurements from an echo compared with CMR in 195 patients with hypertrophic cardiomyopathy. So they found that actually 50% of these patients has measurement discrepancy more than 10%. So commonly what happened is an overestimation by an echo, which occur about 60%. So if you can imagine, if you put the ultrasound probe a little bit oblique, you can actually overestimate the LV wall thickness. And if you don't have a really good visualization, sometimes you can actually include the LV wall or LV trabeculation, papillary muscle or apical septal bundle. So that make it overestimate LV wall thickness. You can also underestimate LV wall thickness by an echo if you have poor acoustic window or if you have focal LV hypertrophy, which you can well visualize by an echo. Only 7% were coming from CMR error. So let's look at this image here. This is an image from the CMR. You measure the LV wall thickness here and you got 1.7. Imagine if you try to obtain the parasternal long axis, instead of cutting through here perpendicular, you actually cut a little bit oblique and you measured here, you got 2.2 centimeters. So that's half a centimeter different. Or if you look at the this lower image here, this is CMR image. You can clearly see this is LV wall and this is part of the RV. But with an echo, with poor visualization, sometimes you can't really see that well, and you actually measure the whole LV and RV and actually got 2.9 centimeters. Or in this case, you actually include the LV trabeculation and got 3.3. which this actually has clinical implication because more than 3 centimeters, you actually consider high risk feature and actually probably gonna need ICD placement. So you actually change management of the patients. And you can also underestimate, most commonly if you have focal SCM or if you have apical SCM, which can sometimes be difficult to visualize from an echo, especially if you foreshorten the LV or if you have poor image quality and you didn't use echo contrast. And these are the common location that can be missed by an echo. As I showed earlier, the LV apex is sometimes difficult to visualize. The infroseptal wall and also anterolateral wall. So the next indication that you should consider order a CMR and SCM is if you have difficulty differentiate SCM from other disease. So disease that can mimic the SCM, including compensatory hypertrophy, which is what we see in daily practice, such as aortic stenosis, systemic hypertension, or patient with coarctation. Or you can have this rare disease such as glycogen storage disease, lysosomal storage disease, like Fabry disease, or infiltrative cardiomyopathy, which now we see actually more often, especially amyloidosis, since now we have treatment for it. Now people are looking more for amyloidosis, hemochromatosis, sarcoidosis, or even benign conditions such as athlete heart can also mimic SCM and confuse us at times. So what can CMR help? So actually, when we do CMR, one thing that we actually good at is actually tissue characterization. So when we perform an LGE, in these cases, they actually give us more details and can actually help differentiate these from SCM. So in case of amyloidosis, you can see that the LGE show diffuse patchy scar throughout the whole LV, and also sometimes involve the RV and also the left atrium as well. So these are typical feature of amyloidosis. So in Fabry disease, they actually commonly have the scar in the infralateral wall. And also in Fabry disease, we can actually do T1 mapping, which actually in Fabry disease has lower T1 value compared to SCM, which actually usually have high or normal T1 value. So that can also help differentiate Fabry from SCM. So in athlete heart, basically you're gonna see pretty much normal LV function, a little bit enlarged LV, and also the LV thickness probably slightly increase. But what you should not see is any scar or infiltration on the LGE, basically. So let's get to this case. This is a 42-year-old gentleman actually referred from outside hospital for heart failure management. So they actually did an echo outside hospital, saw that the septal wall is a little bit thick. They got about 1.9 centimeters from an echo. And patient had full-blown heart failure. So they were concerned if this is SCM or this is actually infiltrative disease. So his age was not, typical for amyloidosis, like in the old age or something like that. So they not quite sure. That's why we order a CMR in this case. And if you look at this LGE, you probably can tell this is most likely going to be amyloidosis. There's a diffuse patchy scar throughout the whole LV, and also in this long axis can also clearly visualize all the scar throughout the LV. So this patient actually got advanced heart failure treatment, and finally he actually got a heart transplant, and now he's been doing well. So CMRs can actually help differentiate this from HOCM. So the next indication for CMR is now an emerging role of CMR for sudden cardiac death risk stratification. So when we perform an LGE, the common scar pattern what we see is non-CD related pattern. It's usually patchy mid-wall, as you can see from here, usually involved in the segment that has hypertrophy. So, and also sometimes at the RV insertion. These can actually help differentiate SCM from other disease. So in one of the meta-analysis of nearly 3,000 patients, the presence of LGE was associated with 3-fold increase in risk for sudden cardiac death, 2.9-fold increased risk of cardiovascular mortality, and 1.8-fold increase in all-cause mortality. But the problem is the sudden cardiac death rate is about 1% per year, and 50% of these patients actually had positive LGE. So at this point, we probably can't use the presence or absence of LGE alone as indication for ICD. So there's actually registry from Cleveland Clinic, nearly 1,500 patients with preserved EF. So they actually look into both obstructive and non-obstructive hypertrophic cardiomyopathy, and they found that the high-risk feature for high risk for sudden cardiac death or ICD discharge is when we have presence of LGE more than 15% of LE in both with and without obstruction. As you can see, the follow-up of 9 years, there's two clear separation between the CV events and the inpatient with LGE more than 15% and less than 15%. So what's the guideline said right now is that, so if you, for ICD, so if you have hypertrophic cardiomyopathy, if you had cardiac arrest or sustained VT, definitely get ICD. And if you doesn't have that, but you have family history of sudden cardiac death, have LV wall thickness more than 3 centimeters, or any recent syncope less than 6 months, then that's class 2 indication for ICD. If you don't have any of those, but you have non-sustained VT, abnormal blood pressure response during exercise, then you have to look at sudden cardiac death risk modifier. So these are including if you're young, less than 30 years old, if you have delay hyperenhancement on MRI, if you have LVOT obstruction, if you have any syncope episode more than 5 years ago, or if you have any high-risk features such as LV aneurysm and LVEF less than 50%, then ICD is indicated. So let's look at this case. So this is a patient, 67-year-old female with known history of hypertrophic cardiomyopathy. So she had recent palpitation, no syncope. She actually had non-sustained VT, 17 beats per minute on the Holter. And the echo show normal LV function, no LV obstruction, also has mid-wall gradient of 30. So as you can see on this still image that there's clearly an LV apical aneurysm. And so when we perform an LGE, you can see a diffuse patchy scar pattern throughout the whole LV. The maximum LV wall thickness is 2.3 centimeters, and the total scar burden is 17% of the whole LV. There's no LVOT obstruction, and patient also have LV apical aneurysm. So if we look at the guideline, she actually has risk modifier of positive delay enhancement, hyperenhancement on the MRI, and also high-risk feature of LV aneurysm. So in her case, CMR actually helped us identify that she actually, have indication for ICD, class 2 indication in her case, and she actually received ICD placement. So in summary, we should consider cardiac MRI for hypertrophic cardiomyopathy patients. in case we need an accurate LV measurement, we're not sure from echo standpoint if we concern about this could be focal hypertrophic cardiomyopathy, or it could be apical whole hypertrophic cardiomyopathy that we can't see well from an echo, or if we need differentiating SCM from other disease. And also right now, if you have like the last case that we have, patient, with no clear indication for ICD yet, has some non-sustained VT on Holter, then we probably should consider order and cardiac MRI to look for LGE to see if she actually has any high-risk feature or risk modifier that we should consider ICD placement for the patient. Thank you.
Great. That was an excellent presentation, Prim. We've got time for 1 or 2 questions from the audience. If anybody from Houston Methodist has a question, you can either type it in the chat box or you can hit the raise a hand and I can actually call on you. And while we're giving the audience a chance to construe their questions, let me ask you, Prim. I think you did a nice job at showing us how some of the mimickers of the differential diagnosis with hypertrophic cardiomyopathy can be amyloidosis or Anderson Fabry disease. And that's where, based on the pattern of LGE or T1 mapping data, can help to kind of differentiate between the two. Another challenge that oftentimes comes up is differentiating between hypertrophic cardiomyopathy and athlete's heart.
Yes.
And somebody who, says, hey, I do some exercise, or, maybe not a pro athlete, or sometimes even a pro athlete. And the question there is, how would you approach in that case? And that's a challenging, obviously, distinction, but how would you approach it in that case?
I think T1 mapping can still help technically, because commonly in the SCM, the T1 value should be slightly higher than normal population. Right?
Yeah. And I think there's some data also that maybe ECV may be helpful as well, in the sense that athletes tend to get more myocyte hypertrophy, and so the ECVs tend to be a little bit on the lower side,
right,
versus patients with hypertrophic cardiomyopathy. But I think it's obviously requires kind of integrating everything together, looking at all the imaging findings as well as everything else, and that's a challenging distinction oftentimes to make. Yep. Any other questions from anybody else here at Houston Methodist? Okay. If not, then thank you very much, Prim. And why don't we move on to our next speaker? And our next speaker is going to be Dr. Basil Al-Sabeq. And Basil is joining us here from University of Western Ontario, where he came from 2 years ago. And Basil has been doing multimodality imaging training as well, in cardiac MRI, as well as cardiac CT and nuclear cardiology. Basil is going to talk to us about the role of cardiac CT in TAVR and pre-procedural planning. And I believe Basil's plans after he finishes here next month are to move a little bit further north, not all the way to Canada, but to University of Tennessee in Memphis, where he'll be a multimodality imager. So Basil, pleasure having you with us, and please take it away.
All right, thanks so much, Dr. Shah, and thanks to everyone else for tuning in. So I'm going to be presenting on the role of cardiac CT in pre-procedural TAVR planning, given that it's something that we do every day here, given that we're a high volume TAVR center. It's going to be kind of a whirlwind tour, just given the time constraints, and it's quite a large topic, but my objectives are to provide a brief overview of the role of cardiac CT in TAVR planning, emphasize the elements to include in our imaging reports for use by the heart team, of which nowadays the imager, whether it's cardiologist or radiologist, is now an integral part. And to highlight focused recommendations from the Society of Cardiovascular CT 2019 TAVR Planning Consensus Statement. No disclosures. So just a bit of a background, the TAVR indications have gradually expanded over the years to not just patients with severe symptomatic aortic stenosis who have prohibitive or high risk, who are prohibitive or high risk for cardiac surgery, but also now who are intermediate or of low surgical risk. And cardiac CT has really become the gold standard imaging modality for aortic annulus sizing, pre-TAVR risk assessment, including the potential risk of annular injury or coronary occlusion, peripheral access assessment, prediction of fluoroscopic deployment angle by the operator, and also for post-procedural evaluation, though I'm not going to touch on that in this talk. In terms of data acquisition and reconstruction, this really varies depending on the scanner manufacturer, the specific system that you're using, and of course, institutional preferences. Here we use the dual source Siemens Somatom Force for the majority of our TAVR imaging reports. The key components that we want are an ECG-gated CT angiogram of the aortic root, a non-ECG gated CT of the aorto-iliofemoral vasculature, and ideally you want those in a single scan with a single IV contrast administration. So in terms of the aortic root acquisition, one has to be mindful that the annulus isn't static, but it's a dynamic structure that changes in size and conformation during the cardiac cycle. The annulus dimensions are essential for TAVR valve sizing, and that for these reasons, it should be an ECG-gated acquisition that at minimum includes a systolic component. It might be useful in some circumstances to include a diastolic component as well, for example, those with septal hypertrophy, or to include the entire cardiac cycle. Also, something to mention, when you're doing the ECG-gated component, it can be just of the aortic root, or it can include the entire heart, or in some circumstances, the entire thorax. If you include the entire thorax, then you do not need to include that for the non-ECG gated portion, and just should include the abdomen and pelvis, since you already have obtained the thorax imaging. In terms of the aorto-iliofemoral acquisition, this does not need to be ECG gated because motion is much more minimal of the structures that you're evaluating, but it should include the thoracic and abdominal aorta, the iliac arteries, and the common femoral arteries. And this is by and large, or predominantly, to look for what is the best access route, transfemoral being the most common in over 90% of cases. If needed, you can extend the scan to include the subclavian and carotid arteries as potential access routes and evaluate those as well. We always want to follow the ALARA, or as low as reasonably achievable principles for radiation exposure to patients. For example, using tube voltage of 100 kV if patients have a BMI less than 30. Using the lowest tube current for acceptable image noise. But of course, we have to balance that with the need for diagnostic quality imaging and not having to repeat the study or repeat contrast administration, especially given that a lot of TAVR patients will have compromised renal function. In terms of patient preparation, you want a peripheral IV that's in the antecubital location, at least 20 gauge in size. Contrary to a coronary CT angiogram, nitrates are contraindicated. And you have to use caution whenever beta blockers are considered. They're not routinely recommended, also for hemodynamic reasons in these patients. And you want to consider cautious IV hydration if there's significant renal impairment, for example, with an estimated GFR less than 30. Non-contrast CTs are not obligatory parts of the study acquisition, but they might be helpful to create aortic valve calcification in certain circumstances. For example, the entity of low flow, low gradient, severe aortic stenosis with preserved ejection fraction. Calculating the aortic valve calcium score uses the same principle as coronary artery calcium scoring, which is basically the area times the density of the calcium. but it can actually be much more challenging than it looks, in the sense that you want to only include the annulus and aortic valve cusp calcium, and be mindful to exclude calcium in the aortic root, LV outflow tract, mitral annulus, and coronary arteries, which are adjacent structures that might throw off your ultimate value. A score that's greater than 2,000 in males or 1,300 in females is associated with an effective aortic valve area less than 1 square centimeter by echo, using the continuity equation, with a fairly decent sensitivity and specificity of around 80 to 85%. When we're assessing the aortic root, you need to be intimately familiar with its anatomy. It's a dynamic structure that extends from the aortic annulus at the basal hinge points of the valve cusps to the sinotubular junction, and it includes the sinuses of Valsalva, the fibrous interleaflet triangles, as well as the valve cusps. The dimensions to include in your reporting are the root, the STJ dimension and height, as well as the coronary osteal height, which is a line that's perpendicular to the annulus plane to the inferior edges of the ostia. There used to be a minimal height of 12 millimeters for the coronary osteal heights that was emphasized to kind of weigh the risk of coronary occlusion, but it's important to note that that's not the only determinant. You also need to be aware of valve cusp calcification, as well as the shallowness of the STJ when you're trying to make that assessment of risk on an individual basis. The aortic annulus, to measure its dimensions, you have to find a plane that transects the 3 lowest cusp hinge points, followed by a contouring of the annulus. And this can be done manually, or there are automated ways with software that can do this. And with that information, you can obtain an annulus area, which historically was used in predicting the size of the balloon expandable TAVR valves, a perimeter, and the short and long axis dimensions. You also want to describe the landing zone, or the LV outflow tract calcification, because this can be important when assessing for the risk of annular rupture. So you want to assess the location and the extent of the LV outflow tract, not just how deep it is into the LV outflow tract, the calcification, but also radially into the lumen of the LVOT, since it can be associated with the risk of rupture or paravalvular leak as well if a valve is undersized. You want to comment on the valve morphology. Most of our patients, because it's approved for this, are tricuspid valves, but in case you have a bicuspid valve, you want to classify it and describe it. Most commonly, we use the surgical Sievers classification. And you also want to look concomitantly for associated aortopathy, which occurs in at least 50% of our bicuspid valve patients. You can, in terms of fluoroscopic angle,
no, and it's called Get with the Guidelines, which, you know, obviously.
In terms of vascular access, the feasibility of transfemoral access can be assessed with CT. So you're looking at iliofemoral vessel size. The minimal threshold for the luminal diameter has changed over the years as sheaths have gotten smaller. But typically you'd want, you know, a luminal diameter greater than 6.5, 7 millimeters in the common femoral arteries. You also want to comment on artery calcification, specifically if the calcification is circumferential or near circumferential, so-called horseshoe calcifications, which can prevent vessel expansion when the sheath is inserted. And you also want to comment on tortuosity, which is also more relevant when there's calcification. Otherwise, it can often be tortuous vessel can be straightened out. You want to comment on the access site, if there's any anterior calcifications, where the puncture site will be, and of course, if there's any aneurysms or ascending aortic calcification or a porcelain aorta as well, and to assess alternate access routes if and when feasible and pertinent. Coronary artery assessment can often be challenging in these patients because they often have concomitant CAD with heavy calcification. Nitrates can't be used or should not be used for the TAVR data acquisition, and they often have elevated heart rates or arrhythmia or motion or a combination thereof. But if image quality permits, we should report the coronary arteries as well, because there's still a high negative predictive value for excluding obstructive stenosis in these patients, and any coronary anomalies should be mentioned as well. This is the last final point on the non-cardiac incidental findings, which are also very important since you're imaging a large portion of, you're obtaining a large portion of data from the thorax and abdomen. It's also institution specific how these should be included, whether it's a separate read from our radiology colleagues or a combined report, but also something not to miss because non-cardiac findings can and do affect clinical management of TAVR patients as well. So that's pretty much it. Thank you everyone for your attention.
All right, that's very nice, Basil. So I think you highlighted very nicely how cardiac CT really, I mean, this is a new application that 10 years ago did not exist, use of this for TAVR planning. And I think as the technology has continued to evolve, I mean, the images that are produced are unbelievable. Maybe if you could give me a couple of pieces of information. One is, what's the contrast dose that's required? And then what are the strategies that you do in patients who have some underlying renal insufficiency? And then the other is there, I noticed you mentioned that simple calcium score of the aortic valve could actually help you to identify that someone has severe AS. Is there any role for anatomic assessment of the valve, so planimetry of the valve area? Is there any data on that? And is there any data between trileaflet versus bicuspid valves?
Okay, so I'll try to answer as best I can. So the first question, contrast dose. For these studies, typically here we use about 100 cc's of iodinated contrast. I think it's probably institution specific. For our typical CTAs, it can be anywhere from 60 to 120. But here I know it's around 100 cc's that we use. In terms of what we do for patients with renal dysfunction, also it probably differs from place to place, but we always, can be GFR cutoffs or creatinine cutoffs for patients. And if there's a sense that, there's a higher risk for tipping the patient into worsening renal dysfunction, sometimes get our renal colleagues involved for advice on hydration prior to the procedure. But I think there's nuances and differences from place to place. In terms of, I think you asked about the calcium score.
So basically being able to assess the valve area in one setting beyond just a calcium score, which has, I presume, a high specificity, but not necessarily high sensitivity.
Yes. Okay. So, I mean, my take on it is the calcium score is more of a tiebreaker than anything else. So it should not be solely relied upon the calcium score nor an anatomic planimetry to make the diagnosis of severe aortic stenosis. It's really when there might be uncertainty, and that's why I mentioned the low flow, low gradient example with a preserved ejection fraction. I think that's where it's most important. But really, transthoracic echocardiography or a repeat TTE, if the first one doesn't answer the question, if there was suboptimal aortic valve stenosis jet on the first one, making sure you use a PDOF probe, looking at it from all windows, the suprasternal notch, right sternal border, apical views, of course. So yeah, I think I'm not aware of the data of using an anatomic planimetered area on CT and how that compares to echo, but really echo should be the predominant modality, transthoracic, for obtaining the diagnosis, and the calcium score is a tiebreaker, if anything.
Great. Okay, well, great. That was a fantastic presentation, Basil. And I guess next we'll move on to Dr. Maan Malahfji. Maan came to us from Houston Methodist. Maan was a general cardiology fellow here at Houston Methodist, and then has been here for the last year doing training in advanced CMR. And Maan is, fortunately, we're able to keep him here. So Maan's going to stay on at faculty with us starting in July. So we'll put him to work right away. And Maan is going to talk to us about the role of CMR for assessment of aortic stenosis. Aortic regurgitation. So Maan, take it away.
Thank you, Dr. Shah, and thank you for the great introduction and the mentorship over the years. Let me find my slides. As you can see, we're a highly collegial imaging fellowship, so Basil and I use the same account here. Okay, and I'm going to try to make this brief. So I'm going to talk about CMR assessment of chronic AI and some of the work we've done over the past year. And to give you a bit of the scope of the problem and some background, why is it that there's such a great focus on valvular heart disease, whether it's structural interventions or non-invasive imaging? It's primarily because we have a highly increasing population that is octogenarians, increasing in age, and these patients are more likely to develop valve disease. There is an echocardiographic screening study out of the UK that shows an increasing prevalence of newly diagnosed valve disease, whether it's mild, and the green here, as well as moderate and severe. And the challenges of treating these patients occur around multiple areas, whether it's assessing their symptoms, whether it's minimizing the risk of interventions, and whether it's also deciding the optimal risk, the optimal timing for intervention. And in this study, the projection was that the number of patients with undiagnosed, newly discovered valve disease might double within the next 40 years or so. In this study, you notice that aortic regurgitation out of the big box in the patients who did not have any known valvular disease represented a significant proportion. Mitral regurgitation is here, and aortic stenosis is definitely more common than this, but I suspect it's because it's primarily detected on physical exam, and it's much easier to diagnose versus aortic regurgitation by instrument examination. We have multiple practice guidelines in the area of valve disease, whether it's treatment or evaluation by echocardiography, CMR, and cardiac CT. And these guidelines give us multiple areas and questions that can guide us towards performing research studies and answering unanswered questions. And I wanted to start by showing you a sample of the studies that delineated how we treat and assess aortic regurgitation. These are all landmark studies that, if you notice, happened mostly in the 80s and the 90s, and they were relatively smaller sample size. If you notice, particularly for aortic regurgitation, the primary cohort of these patient groups were actually younger patients. And CMR has really become almost routine in many centers, particularly here, in assessing valvular disease, particularly when there is suboptimal echocardiographic images, whether there's any discordance between what we find on the echo and the Doppler measurements or the physical exam, when we want to assess the aorta for aneurysms and dissections, and in the cases of mixed valvular disease. There's multiple ways of looking at aortic regurgitation using CMR. We can directly quantitate the regurgitant volume by a phase contrast imaging at the sinotubular junction. We could compare the forward stroke volume through the aorta and through the pulmonary artery and look at the difference between the two. We can look at an anatomic regurgitant orifice area for further reference, and we can assess whole diastolic flow reversal. And CMR is already supported by pretty strong evidence in its ability to predict outcomes. So this is a study from Oxford in the UK in 2012, where patients were followed after performance of CMR and quantification of regurgitation severity. An assessment of regurgitation severity by a fraction of greater than 33% was highly able to predict the need for AVR or developing symptoms for AVR. Another smaller study from the University of Washington included 29 patients with AR, and albeit with small numbers, the number of the AUC for predictability for needing AVR was relatively stronger for CMR compared to echocardiographic quantification. What about reverse remodeling? There is a study from a Belgian group that looked at reverse remodeling by CMR after AVR for aortic regurgitation. And we know from numerous echo and MUGA studies in the 90s that a lot of the reverse remodeling occurs within the first year after surgery, but it's not always 100% that all patients recover to a normal mass and a normal ventricular geometry. In this study, the vast majority of the patients within about 6 months or so recovered to a normal index ventricular dimensions and volumes, but notice the ventricular mass is still significantly higher than controls here. And there are unfortunately no studies that looked at long-term reverse remodeling to see if the mass truly decreases down to normal. And where are the areas that we thought we could look at? In the general realm of valve disease, the questions can arise around whether we can prevent valve disease, whether we can treat valve disease with medical therapy and prevent progression. And then the major one where most of the non-invasive imaging revolves around is trying to determine the optimal time for intervention. So we want to try to look at AV repair or replacement at the right time for the right patient and minimize the risk. There's always questions that have arisen around whether there should be age or sex-specific thresholds for intervention and how patients with different age groups or different genders respond differently to valve disease. One of the also important ones are biomarkers that can detect subclinical LV dysfunction, where potentially intervention, even in a non-symptomatic or mildly symptomatic patient, might have long-term benefit. And obviously, as you saw with the previous CMR study, the assessment of regurgitant fraction that we get from CMR has not been definitively proven to be the same range as we get with echocardiography, because there's a lot of variation in the methods and assessment of ventricular size and volume. Now, this study came out recently, and it showed that there's still areas for further improvement. This study also came out of Belgium from the same group, and they looked at patients who underwent AV replacement or repair. Their experience was primarily with AV repair. And they looked at patients who had a guideline indication to treat AR, whether it's class 1 or class 2 indication, and compared them to patients who were operated on without definitively meeting any of the guideline criteria. And as you can see with adjusted and non-adjusted analyses, the patients who did not have any triggers for meeting guideline indications for intervention appear to do slightly better. This is an older study from the Mayo Clinic, which was published in the 90s, and I presume the data was primarily in the 80s. And this highlights the question about whether there are any gender differences in remodeling to AR and how that translates into outcomes. In this study, the authors found that women appear to have poorer outcomes compared to men, whether it's overall survival and including operative mortality, and then survival after aortic valve replacement. And in this period, there wasn't any clear indication to try to index LV diameter for body surface area. So the generalization that men and women will have to meet the same LV diameter potentially resulted in women getting operated on at a later date and potentially developing, higher severity of symptoms and might have led to poorer outcomes. Now, this study hasn't really been replicated, and I think that's primarily because afterwards there was more aggressive treatment, and patients and institutions started treating patients according to data that emerged afterwards, which showed us that indexing LV diameters to body surface area might be beneficial to try to prevent long-term poor outcomes after the operation. So where does CMR come into this particular question? There isn't really any CMR data that describe how genders differ in their remodeling. And CMR really represents an ideal strategy to investigate this question because we can look at LV mass and volumes with high accuracy, high reproducibility, and without the need for any geometric assumptions, particularly when it comes to LV mass. So we hypothesized that gender will influence this remodeling. We wanted to look at tissue characterization, ventricular mass, ventricular volumes in men and women who have matched degree of aortic regurgitation assessed by CMR. And we wanted to see how indexing to BSA affects these CMR measurements. So we looked at 560 patients. We excluded patients with confounding factors such as coronary heart disease, primary cardiomyopathy, prior cardiac mass, congenital heart disease. And we ended with what's considered here an isolated chronic AR population of 280 folks. As you can see, we have what I consider to be a strong number of women in this cohort. If you look at the previous cohorts that I described, generally the number of women in these cohorts was really less than a quarter, because AR is significantly more prevalent in men, particularly that men also have more, they are more likely to have bicuspid aortic valves. What we found is for a matched degree of aortic regurgitation matched by regurgitant volume here across 3 tertiles, men will, as expected, have a higher index, non-index LV end diastolic volume, LV insystolic volume, and LV mass. Once we looked at indexing to body surface area at tertile 1 of regurgitant volume, men will still have a slightly higher index volume than women. As you progress towards significant AR in tertiles 2 and 3, there isn't really significant differences in the volumes, whether it's end diastolic volume or insystolic volume. What about mass? In ventricular mass, there is still actually a significant difference between men and women. And that led us to also look at changes in cellular and extracellular volume as manifested here by ECV. And the hypothesis was that since men appear to have a higher index LV mass, even after you index it compared to women, it could be that the remodeling of men occurs both on the cellular space as well as the extracellular space. Whereas here, as we notice in women, there appears to be a significant increase in the extracellular space as the degree of AR increases, whereas in men, it appears to be flat. Here's an example. Here's a man and a woman with similar degrees of LV dilatation and a similar degree of regurgitant fraction of AR. And this is what we appear to be noticing in these cohorts. In this case, the man had an ECV of 26%, whereas the woman had an ECV of 34%. Now, how this translates into clinical symptomology, progression to need for AVR, potentially reverse remodeling differences between men and women is still yet to be determined. But we conclude that with CMR, we're still able to demonstrate significant differences between men and women with regards to LV mass, even at higher degrees of regurgitation severity and after indexing to body surface area. Now, you might ask, what about late gadolinium enhancement? Late gadolinium enhancement is, as you know, is very powerful in multiple cardiovascular disease states and has really high prognostic value. I didn't really show you any outcomes or symptoms assessment for that previous study, which was primarily descriptive. So we looked at how LGE in an isolated AR cohort affects outcome. And in this case, we looked at total mortality. Here are some examples of how LGE manifests in AR patients. We might have the patchy midmural scar in the infraarticular septum, non-CAD scar in the anterolateral wall as well here. And then you might also have an infarction pattern scar here in the infralateral wall. Here's a study that was primarily done in AS patient and included 5 or so aortic regurgitation patients. And this study was powerful because it correlated the findings of late gadolinium enhancement against pathology. And they also correlated these findings of fibrosis, both on the tissue level as well as on the CMR level, with outcomes, and the primary outcome was survival as well. And as we've established in multiple other disease states, there is pretty reasonable correlation between histopathologic assessment of fibrosis and late gadolinium enhancement. And we aim to look at chronic AR, isolated as well, and the patterns of scarring or LGE and how these associate with mortality. So we looked at a different cohort of 550 patients. This time it was patients with moderate or severe chronic AR, assessed by CMR as well. We excluded patients who had other confounding causes of scarring similar to the previous study. And we categorized scarring on the CMR as an infarction or non-infarction pattern. The primary outcome, as I mentioned, was all-cause mortality. We excluded patients similar to the previous study, but we paid particular attention here to show that we definitely excluded patients with significant aortic valve disease, including mitral valve disease or any prosthetic interventions. And we followed patients for whether they had aortic valve replacement or were treated medically. And I'll show you parts of the results in the interest of time. What we found is in patients with moderate or severe chronic AR on CMR, patients who had any extent of myocardial scarring do significantly worse with regards to their survival compared to patients who did not have any scarring. And that persisted on both adjusted and non-adjusted analyses. When we looked at the pattern of scar, as well as other sensitivity analyses trying to exclude patients with coronary artery disease, for example, or patients with low ejection fraction, the adjusted analyses still showed that the presence of any scar was significantly associated with mortality. And this, while not necessarily being the same finding as we have in aortic stenosis, it might be significant in that it could lead to us potentially treating patients with scarring a little bit more aggressively with aortic valve replacement if we can replicate these findings and further show this value of this assessment. So we concluded that myocardial scar was essentially independently associated with a 2.5-fold increase in mortality. Both infarction and non-infarction scar are independently associated with increased risk of death. And obviously, we're going to do more research to see if the detection of scar could identify AR patients with maladaptive remodeling or whether earlier surgery can lead to improved outcomes in patients with AR and myocardial scarring, similar to what we know in aortic stenosis. Thank you.
Maan, that was an excellent presentation. Thank you very much. So let me maybe ask you a question similar to what I asked Basil, which is with regard to renal failure. What can you do for patients who have renal insufficiency in the setting of AR? And I guess be looking at it from the standpoint of what you want to try to identify is, one is the anatomy of the valve, assess severity of regurgitation, and then assess the remodeling of the ventricle.
Yeah, CMR is, as we all know, is pretty powerful in valvular characterization, particularly from the standpoint that we don't necessarily need gadolinium enhancement for assessment of ventricular volume, assessment of ventricular function, as well as regurgitation severity. So the gadolinium contrast is not needed for the severity assessment piece, which is primarily the goal of the study in most of these patients. Now, with regards to tissue characterization, is still limited by our relative inability to administer gadolinium in patients who have a GFR less than 30, although that might change in the future because the newer gadolinium contrast agents appear to be safe even in patients with severe renal insufficiency. But it might be reasonable, and we're going to look at native T1 mapping in patients with AR, which can be performed without needing to administer contrast. Native T1 mapping has proved to be highly beneficial in multiple disease states, particularly amyloidosis, who are very often, people who suffer from severe renal disease. But I would say, like I always say, stay tuned.
All right, great. Well, let me get all the speakers from today up. Prim, Basil, and Maan. Really, I want to thank all three of you, one, for an outstanding presentation today, and more importantly, really for all the hard work that you've done over the last year or 2 years. I think we've all really enjoyed having you here with us. We certainly wish you all the best in the next step in your career, and we look forward to staying in touch. All right, thank you very much. And thanks everybody for tuning in, and we'll see you again next week.
Thank you.